Welcome to the deep dive. We've got Porth's Pathophysiology, chapter 43, in front of us, and it's quite the journey through the male genitourinary system.
It really is a very systematic look. Our goal here is to pull out the key ideas about, structural defects, inflammation, neoplasms, all that stuff.
Right, focusing specifically on how these things mess with urine elimination, sexual function, and fertility. That's the core mission.
Exactly. Think of it as the essential guide to what can go wrong, pathologically speaking.
Okay, so to make this manageable, we're tackling it organ by organ. First up, the penis. Then, the scrotum and testes. And finally, the prostate. Sound good?
Perfect. Let's start with the penis, and specifically things that can be present right from birth. Congenital defects.
You mean like hypospadias and epispadias?
Precisely. It all comes down to where the urethra decides to open up during development.
Okay, so hypospadias. That's when the opening's on the underside, right? The ventral surface. Could be anywhere along the shaft, even scrotum or perineum.
Exactly. And it's the more common one, maybe 1 in 350 births. Sometimes you'll see it alongside chordae.
Chordae. That's the downward curve.
Yeah, a ventral bowing of the penis. Or sometimes with cryptorchidism, which we'll get to later.
And the opposite is epispadias,
Yeah.
opening on the top, the dorsal side.
Correct. Less common, but still significant. Now, the real point with severe hypospadias is the need for surgery.
And that's not just for looks, is it?
Oh, definitely not. We're talking about preserving normal urinary and sexual function down the line. Ideally, that repair happens between, say, 6 and 18 months of age.
Okay, moving from congenital to acquired issues. Foreskin problems. Phimosis and paraphimosis. Need to keep these straight.
Absolutely critical distinction. Phimosis is just a tight foreskin prepuce that you can't retract back over the glands.
You shouldn't force it in kids.
Definitely not. But in adults, if it's causing problems, circumcision is often the answer. And interestingly, Porth notes symptomatic phimosis is a risk factor for penile cancer.
But paraphimosis, that's the urgent one.
That's the crisis, yeah. The foreskin is retracted, but it gets trapped behind the glands, acting like a constricting band.
Cutting off blood flow.
Potentially, yes. It can lead to ischemia, even necrosis. It's a genuine medical emergency. Needs immediate reduction.
Okay, let's talk inflammation and fibrosis.
Yeah.
Balanitis comes up.
Right, balanitis is inflammation just of the glands. If it involves the foreskin too, it's balanoposthitis.
And Porth links this often to uncircumcised men, maybe poor hygiene or diabetes.
Yeah, those are common factors. The cause can be anything from candida, HPV, even just irritation or trauma.
Then there's Peyronie disease. This sounds different. Fibrosis.
It is different. It's this localized progressive scarring, basically. A dense fibrous plaque forms in the tunica albuginea, that's the tissue sheath around the erectile bodies.
Usually on the top.
Often on the dorsal midline, yeah. And the result? The penis bends or curves upwards during erection, and it's often painful. Interferes with sex, obviously.
Which brings us neatly to erectile dysfunction, or ED. Let's quickly cover how erections even work first.
Okay, the basics. It's a neurovascular process. Starts with parasympathetic nerve signals.
Relax and restore nerves.
Right. They trigger the release of nitric oxide, NO.
Right.
NO then activates an enzyme which boosts levels of something called CGMP.
CGMP. That's the key player.
That's the magic molecule here. It makes the smooth muscle in the arteries and the erectile tissue relax.
So more blood flows in.
A lot more blood flows in, and at the same time, the expanding tissue presses on the veins, trapping the blood. That's the veno-occlusive part.
And getting rid of the erection. Detumescence.
That's the sympathetic nervous system kicking in, the off switch.
Okay, so ED is the persistent inability to get or keep that erection going. It used to be all psychological, right?
But that was the old thinking. Now we know for most guys, especially as they get older, there's an underlying physical cause, an organic cause.
And number one is often
vascular problems, arteriosclerosis. Same gunk that clogs heart arteries can clog the smaller penile arteries.
which Porth really emphasizes, the link between ED risk factors and heart disease risk factors.
Absolutely. Obesity, smoking, high cholesterol, diabetes, it's all the same stuff. And here's the kicker. Sometimes ED shows up before other signs of heart disease.
Wow. So it can be an early warning sign. What's the underlying mechanism linking ED and things like metabolic syndrome?
It often comes down to endothelial dysfunction. The endothelium is the inner lining of your blood vessels. Healthy endothelial cells release that crucial nitric oxide.
Ah, so if the lining is damaged, like in diabetes or atherosclerosis.
It doesn't release NO properly. Less NO means less relaxation, less blood flow. The vessels just aren't healthy enough to support a reliable erection. It's a sign of systemic vascular trouble.
That really reframes ED, doesn't it? It's not just a local issue.
Not at all. Beyond vascular, you also have neurologic causes, think nerve damage from diabetes, spinal cord injuries, Parkinson's, and lots of common meds can contribute to antidepressants, blood pressure drugs.
And treatments often target that CGMP pathway, like PDE5 inhibitors.
Exactly. Drugs like sildenafil work by stopping the breakdown of CGMP so it hangs around longer, promoting relaxation.
But the big warning label.
Huge GE warning, never ever mix PDE5 inhibitors with nitrates, the kind used for chest pain. The combined effect can cause a catastrophic drop in blood pressure.
Life-threatening. What are the alternatives then?
Well, there are vacuum devices or intracavernosal injections, ICI, where medication is injected directly into the penis.
Okay, one last penile emergency. Priapism.
Right. This is an erection that just won't go away, lasts more than 4 hours, and it's not related to sexual desire or stimulation.
And it's an emergency because
That trapped, stagnant blood loses oxygen. It leads to ischemia, tissue damage, and potentially permanent impotence if not treated quickly.
Are there different types?
Yeah, mainly two. Ischemic or low-flow priapism is the common one. The penis is fully rigid, painful, tender. That's the real time-critical emergency. Then there's non-ischemic or high flow, often from trauma, usually less rigid and less painful.
Okay, let's shift gears now. Down to the scrotum and testes. Again, starting with congenital issues.
Yeah.
Cryptorchidism.
Undescended testes, simple as that. One or both testicles just don't make the full journey down into the scrotum during fetal development.
And Porth says this is the most common congenital GU issue in baby boys, especially preemies.
That's right, significantly more common in premature infants.
And not fixing it leads to big problems later.
Really serious ones. We're talking infertility, a massively increased risk, like 20 to 40 times, of developing testicular cancer later in life, and also about a 10-fold higher risk of testicular torsion.
So surgery to bring the testes down, or cupexy, is standard.
Absolutely. It mitigates those risks significantly.
Okay, what about fluid collections in the scrotum? There are a few different selections.
Right, let's tick them off. Hydrocele. That's just clear fluid collecting in the tunica vaginalis, the sac around the testes. Key diagnostic feature. It should transilluminate.
Shine the light through it.
Exactly. Hematocele. That's blood collecting, usually after trauma. The scrotum might look bruised, dark red, or purple.
Spermatocele.
That's a painless cyst, usually up near the epididymis, and it contains sperm. Should also transilluminate.
And the famous one, varicocele.
Varicocele. Dilated veins in the pampiniform plexus, the network of veins draining the testes, usually on the left side.
And the classic description.
Feel like a bag of worms on palpation. Clinically important because varicoceles are linked to reduced sperm count and motility, so they can impact fertility.
Got it. Moving to another emergency, testicular torsion. You mentioned the increased risk with cryptorchidism.
Yes, but it can happen to anyone, especially adolescents. It's when the spermatic cord twists on itself.
Cutting off the blood supply instantly.
Immediately. And the testicle is very sensitive to lack of oxygen. Viability drops like a stone after about 6 hours. It's a race against time.
How does it present?
Usually sudden, severe pain, often radiating up to the groin. The affected testicle might ride high in the scrotum. Intense distress.
And that key physical exam sign.
The chemosteric reflex is usually absent on the affected side. Stroking the inner thigh normally makes the testis elevate in torsion. That reflex pathway is interrupted, helps distinguish it from infection.
Speaking of infection, epididymitis. Inflammation of the epididymis, that structure behind the testis.
Correct. Usually caused by bacteria traveling backwards up the urinary tract or, in younger men, sexually transmitted infections.
So STIs like chlamydia and gonorrhea in younger guys?
Often, yes. In older men, more likely to be bugs like E. coli from the urinary tract.
And there's a sign for this too, pre-ensign?
Pre-ensign, yeah. Gently lifting the affected testicle often relieves the pain in epididymitis. Doesn't help or might worsen the pain and torsion.
What about orchitis? Inflammation of the testes itself?
Orchitis is less common than epididymitis. The classic cause historically was the mumps virus.
Mumps orchitis. Can that cause permanent damage?
It certainly can. Severe inflammation can destroy the sperm-producing cells, leading to infertility in that testis. Happens in maybe 30% of mumps orchitis cases.
All right, finally for this section, testicular cancer. Porth notes it's rare overall.
But it's the #1 cancer killer in young men, ages 15 to 35. That's the statistic that stands out.
And the biggest risk factor is?
Uncorrected cryptorchidism. by far.
How does it usually show up?
Often just a slight enlargement of the testicle, maybe a dull ache. But the classic sign you have to watch for is a painless lump or mass in the testes. Diagnosis involves ultrasound and, importantly, blood tests for tumor markers. Alpha-fetoprotein, AFP, and beta-HCG are key. Most are germ cell tumors split into seminomas and non-seminomas.
Okay, last major section, the prostate. Small gland, big impact. His main job is making fluid for semen, right?
Yep, produces an alkaline secretion that helps with sperm motility and survival. But it's prone to problems, especially as men age. Let's start with inflammation. Prostatitis.
Porth lists 4 categories, but 3 main symptomatic types.
Right. First is acute bacterial prostatitis, comes on fast. Pelvic pain, maybe pain with urination, plus systemic stuff like fever, chills, feeling unwell.
And the rectal exam needs to be gentle.
Very gentle. You don't want to massage an acutely infected prostate. Vigorously could push bacteria into the bloodstream, causing bacteremia.
Then there's chronic bacterial prostatitis.
This one's sneakier. Often presents as recurrent UTIs in men, without the dramatic fever and chills. It can be really tough to clear the infection completely. Diagnosis hinges on finding bacteria in prostatic fluid samples.
And the most common but fuzzier category.
Chronic prostatitis, chronic pelvic pain syndrome,
Yeah.
CPCPPS. This is the frustrating one. Men have pelvic pain, urinary symptoms, sometimes pain with ejaculation, but often without clear evidence of bacterial infection. The cause isn't always clear, might involve inflammation, nerve issues, muscle tension. It's complex.
Okay, but the disorder everyone associates with the aging prostate is BPH, benign prostatic hyperplasia.
Absolutely. This is just age-related enlargement. The prostate actually has a second growth spurt starting around age 25 or so.
And crucially, where does BPH occur in the prostate?
It develops mainly in the periurethral zone, the area right around the urethra. That's key.
Because it directly squeezes the tube.
Exactly. Contrast that with prostate cancer, which usually starts in the peripheral zones, further away from the urethra initially.
And Porth mentions 2 components to the obstruction in BPH.
Yes. There's the static component, just the physical bulk of the enlarged tissue squishing the urethra, and the dynamic component that's increased smooth muscle tone within the prostate, also constricting the urethra.
Which explains why certain meds work.
Right. Alpha blockers target that dynamic, smooth muscle component, helping to relax the grip on the urethra. Other meds, 5-alpha reductase inhibitors, work on the static part by slowly shrinking the gland size.
Leading to those classic symptoms.
Yeah.
Weak stream, trouble starting, going often, especially at night, nocturia, maybe not emptying completely.
All of the above. And importantly, the size of the prostate on exare doesn't always correlate perfectly with how bad the symptoms are. On DRE, BPH typically feels enlarged, but smooth and rubbery.
Okay, last topic, prostate cancer. The big one.
Most common non-skin cancer in U.S. men. Incidence really climbs after 50, and Porth notes a significantly higher incidence in African-American men.
Pathologically, these are adenocarcinomas. And where do they usually start?
Mostly adenocarcinomas, yes. And typically they arise in those peripheral zones we mentioned.
Which means they might not cause urinary symptoms early on.
Correct. Which is why screening is important. When it metastasizes, it loves bone spine, ribs, pelvis. Bone pain can actually be the first symptom for some men.
Screening involves the PSA blood test and the DRE, the digital rectal exam.
Yes, with the DRE, you're feeling for anything nodular, hard, or fixed on the prostate surface, which would be suspicious for cancer, unlike the smooth feel of BPH.
And diagnosis involves biopsy, then grading and staging.
Exactly. Grading often uses the Gleason score. Lower score means less aggressive cancer. Staging, TNM system, tells you how far it's spread. Treatment options range from active surveillance for low-risk disease to surgery, radical prostatectomy, radiation, and hormonal therapy.
Hormonal therapy often means blocking testosterone.
Primarily, yes. Androgen deprivation therapy, often using GnRH analogs, is a cornerstone for advanced disease.
Wow. Okay, we made it through. From hypospadias and torsion right through BPH and prostate cancer.
Yes.
A lot of ground covered.
Definitely. And you see the recurring themes, right? How these conditions impact urination, fertility, sexual function. But that link we discussed with ED, that's maybe the biggest picture takeaway.
The idea that ED isn't just about the penis, it's often a sign of systemic vascular health problems.
Exactly. The endothelial dysfunction concept, problems with the blood vessel lining. It connects ED directly to things like heart disease, stroke risk, metabolic syndrome. It's all intertwined.
Which really changes how you think about it. It's a potential whole-body warning sign.
A critical one.
So let's leave you, our listener, with a final thought to chew on. We talked a lot about specific treatments, But given that really strong link between overall cardiovascular health and erectile function, could it be that the most powerful preventative strategy for many of these functional male GU issues, particularly ED, is simply aggressively managing those basic cardiovascular risk factors?
You mean like stopping smoking, controlling weight and cholesterol, managing blood pressure and diabetes?
Exactly. Is the best preventive urology actually just good preventive cardiology? Something to think about.
A very powerful connection. Well, thanks for joining us on this deep dive into Porth Chapter 43. We hope this helps clarify these concepts.
Absolutely. Thanks for listening.